I'm Dr. Casper, and the title of the talk is Private Dermatology Practice with a New Multidisciplinary Approach for Non-Surgical Skin Cancer Treatment. And I'm going to kind of go through why we decided to do this and how it's working for us, and it's been really successful. Had a lot of patient satisfaction, and the results have just been absolutely magnificent. I wouldn't even say the results have been good. I classify the results as magnificent. And just to clear, I have no financial disclosures, and I'm not a paid speaker for Intra-Op or any other company. We do a lot of Mohs surgeries in the practice, and this is just a recent patient of mine that had Mohs done about 4 months ago. And he had an infiltrative basal cell in his nose. And so I talked to him about doing the electron therapy versus Mohs. And what they see is that they just see a small biopsy done, because I do small biopsies. So they see a small biopsy, so it can be misleading to the patient on the actual size of the tumor, because the tumor can spread under the skin and you just don't see it. And so a lot of times patients will ask, well, how bad is the Mohs surgery going to be? There's no way to honestly tell them how bad the Mohs surgery is going to be. Mohs surgery in itself is unpredictable, because we're analyzing the tissue and just following the spread of the cancer. So and there's also a recent article. So sometimes these patients, they won't know how spread out the cancer is. They just see a small biopsy. Maybe the biopsy itself is 3 or 4 millimeters, and they think it's not going to be that bad. There was a recent article in JAMA Dermatology that analyzed Mohs surgery and patient expectations. And they found that over 80% of patients underestimated how big the Mohs defect will be and how big the scar was. And on average, the scar was 2 to 3 times larger than what they predicted. And so a lot of times that's consistent in our practice. The patients, they don't realize how large the scar is going to be, or how large the defect is going to be, because of subclinical tumor spread under the skin that they just can't see from the biopsy. So in this particular patient, so I did explain to him about Mohs surgery or electron therapy. I sat down and talked to him, and he still elected to have Mohs over the SET. And I told him, we have an option where it's not going to leave a scar. So we did the Mohs surgery on him, and go to the next slide. Thank you. And so the Mohs surgery ended up taking 5 stages, and it was followed by a skin graft performed the same day by our plastic surgeon. So you see the size of the defect. Go ahead and go to the next. And so then this is the outcome. So he had a skin graft done, and that was the most recent pictures. And he wasn't happy with the overall results, but he also understands that I gave him, before we did anything, I gave him the non-surgical option before proceeding with Mohs, and that he elected for Mohs surgery over the electron therapy. So even though he's not happy with the results, he knows that he had a non-surgical option that was not going to leave a scar, and still has an excellent cure rate. So it's a lot easier to manage this patient's expectations, since we gave him that option. And and particularly in this community that I work in, this retirement community, it's a very tight-knit community. And so these unhappy patients that are unhappy with their surgical scar, I know not only find out from them, but I also find out about from 10 of their friends. So, because a lot of their friends come to see me, and I have to hear it repeated, that how this person's not happy with their surgery scar. So it's not this particular case, but other cases like this is what led me to pursue non-invasive treatments. And as I said earlier, I initially started with the superficial radiation therapy, the SRT, purchased from the census. And this is a machine that's designed, it has a small footprint, and it's designed for the dermatologist to operate. So whereas the electron therapy, which I'm going to go in more about, is a multidisciplinary collaboration with a radiation oncology team. So, but I started doing the SRT about, it's probably back in 2013 or 2014. And I did this because patients like these, they want options. They want non-invasive options. They want to have a choice in what they have and what they're going to have done. Some patients may have a fear of surgery. They're tired of getting cut on. Some just plain hate having Mohs surgery done. They're impatient. They can't wait the 30 minutes to an hour in between layers. And then, others, they're worried about scarring. They don't want skin grafts or reconstructive surgery. There's a lot of advantages, with the SCT, there's no pain, there's no needles. You don't have to worry about bleeding. You don't have to worry about perioperative infections, particularly in patients with medical comorbidities. And we also deal with a lot of diabetics who are poor wound healers, and they get skin cancers on their lower extremities, and they can take 3 months or longer for those wounds to heal. And with all these, it can lead to infection, it can lead to scarring, pain, and ultimately the surgery will lead to poor patient satisfaction and poor patient compliance down the road. So all these brought me to choose a non-invasive treatment. And so I started out with the superficial radiation therapy, which was pretty much all that was available to me at the time. And I did that for 2 to 3 years, and I'd say I was really dissatisfied with the results. I can go in more detail privately with people, but I just don't. But I was just unhappy with the results. Also, it's constantly having my clinic interrupted by having to push the red button. So I was being interrupted throughout the day, having to push the red button, and I'm very busy, so it would slow me down in clinic. And also, if they had questions throughout treatment, I'd have to answer their questions as well, which could also slow my regular clinic down as well. And then lastly, what I really felt uncomfortable about the radiation therapy, this SRT, was that I had this feeling that dermatologists are not trained to do radiation oncology. Like, we had no training in residency. Basically, I felt like, as dermatologists, we don't have our patient's best interest if we're doing the superficial radiation therapy ourselves. So that was just my own personal opinion. I felt like if we're going to be delivering radiation, it should be done by a radiation oncologist. Like, we just don't have sufficient training as dermatologists to be delivering this type of therapy. So I ended up giving up the machine and stopped doing it, and just went back to Mohs surgery. And then my patients would keep asking me about the SRT, why aren't we still doing it? And I have to explain to them. And they would go outside the practice to get radiation done. So a few years later, this is about 2 years ago, as Derek was saying, I looked at different ways, that we could deliver radiation within an office. And I found intra-op online, and I contacted Derek and asked him about doing this project together, and we got on the phone. At the same time, I was talking to my friend Dr. Brabham, and about doing partnering together, and we were actually Jeff and I, we actually talked about building a bunker, doing an actual radiation bunker that was going to be 2 to 3 times the cost. But after talking to intra-op, this sounded like it would work. So, but yeah, prior to this, I was thinking about actually building a bunker where we'd actually have to lease another dermatology office, lease another office space, and build the bunker at 2 to 3 times the cost. So anyway, fast forward, 2 years later, we got the electron therapy, and this is a picture of the intra-op Mobitron machine in our office. and it takes up about, I think it's about 400 square feet. But the beauty of this is that it's a multidisciplinary collaboration with the radiation oncology team, and their sole focus is dedicated to skin cancer treatment, and they do an outstanding job. And in my opinion, it's the best use of the medical and clinical expertise, and has so many advantages for patients, the practice, and the community. And I'm going to go through some of these. But also the advantage of this machine is that it's a small footprint. I think we have about 400 square feet. So and it's great. So and I'm not the one who has to manage it. So I can spend more of my time on patient needs and their outcomes, and making sure my patients are satisfied. So it's just a lot of advantages for patients in the practice and the community. So, and I no longer have to refer them out. We can monitor their progress and also their expectations, and it really ensures their compliance. And all this allows us to deliver superior patient care and outcomes. And most importantly, when we have superior patient care and outcomes, it makes for happy patients and happy doctors. So I'm just going to go through some of the SCT patients that we've treated. So this is a patient of mine that I did a biopsy on his nose. It was a basal cell on the right nasal ala, and that was from January 2020. And I saw him 4 weeks after he finished treatment in April. And I could not tell where anything was done. I looked at it with my microscope, and it was nearly impossible for me to see even where the biopsy was taken. And this guy was thrilled with his results. So very, very happy. And I could not even see where the biopsy was taken. Whereas he had surgery, I guarantee there's going to be a surgical scar there, either a flap or maybe a skin graft. Next patient. This is another patient here that had a basal cell on the right outer canthus, and again, just outstanding results with him. So, and then another thing I wanted to talk about was not just treating the primary tumor, but we can also provide adjuvant radiation therapy. So this is a patient of mine. He's been a patient of mine a long time. He's immunocompromised, or not immunocompromised, but poor health. He has prostate cancer, is being treated for that. But he had an aggressive, deeply infiltrating, poorly differentiated squamous cell on his forehead. And because of the aggressive features, I wanted to send him out for adjuvant radiation therapy. And we can do that in-house. And I explained to this patient, he's been my patient for a long time, and I explained to him, we can do the radiation in-house, or we can refer you outside the practice. I was happy to refer him internally or externally. And it wasn't even a choice for him. He wanted to do it with us, because with us it's convenient. We're close where he lives, and he's already established with our practice. If I had to refer him out, he'd have to get established with a new doc. We have to send the referral, get established with a new doctor. Whereas when it's in-house, I just send an intramail to the SCT group, say, hey, get this guy scheduled for adjuvant radiation. Right away they're scheduled. So he's really happy, and he's going to be starting his treatments here pretty soon. This was another gentleman of mine. This guy, he had an aggressive squamous cell, a poorly differentiated squamous cell on his right ear, and that was the Mohs surgery defect. And because of the aggressive features, we wanted him to have adjuvant radiation therapy, which he had done. And go to the next page. And so this was after the skin. On the left picture was after part of the skin graft healing, and then the right picture on the right is his ear after the electron therapy was done. And again, he just had outstanding results. I mean, just the results are just outstanding. I've seen adjuvant radiation delivered, and the results aren't outstanding, but this machine just delivered outstanding results. So just to kind of summarize, this machine, it's well suited for private dermatology practice. I've been very happy with it. Also been very happy with the support from intra-op, and also the support with Dr. Brabham and his team. Every now and then we'll have some minor issues come up, and we'll get those ironed out like immediately. This is a multidisciplinary approach. It's more affordable, it's less space, and you know, the most thing is just the delivering high patient satisfaction and patient retention, and then the improved continuity of care and the patient compliance just leads to happy patients and happy doctors. And I just let Jeff's group take care of it, you know, and I can just focus on what I'm doing here in the practice, and does give me more time to spend with my family.
As Derek said, I'm the CEO of Set Solution and also a board certified radiation oncologist. Disclaimer, I'm not a paid speaker for intra-op, and like Dr. Casper's presentation, this presentation contains proprietary images that we ask that you not copy or disseminate without written permission. Our national society, ASTRO, recently published a white paper offering definitive guidelines for the use of radiation therapy in non-melanoma skin cancers, both definitively and postoperatively. And in terms of definitive RT, these are the recommendations and the category of strength. In patients who either medically cannot undergo a resection or decline surgical resection, there's a strong recommendation. And in patients for whom surgery can be compromising cosmesis or anatomical function, RT is conditionally recommended. And conditional means that most people would choose the choice, but not all would, and it involves a informed consent process. And the same is true for not recommended, for patients who have genetic diseases predisposing to heightened radiation sensitivity. These are relatively rare diseases such as Gorlin syndrome or ataxia-telangiectasia. Also, the NCCN guidelines support the use of radiation therapy in non-melanoma skin cancer. The NCCN is the National Comprehensive Cancer Network. It's a consortium of 30 of the largest cancer centers in the United States. And they put together guidelines on just about every type of tumor there is. And they have guidelines for both squamous and basal cell. And you'll note they list the different fractionation schemes that they consider appropriate for both early stage and more advanced stage tumors. Almost all the tumors that we treat with SET technology are on the smaller side. Most of them are less than 2 centimeters, but occasionally are larger. But you can see that there's definitely a preference towards more extended fractionation than what I know a lot of dermatologists are used to using when they use the Census device. Census does not, for whatever reason, promote fractionation as much as a radiation oncologist would. And we are big believers in fractionation because, as highlighted there, protracted fractionation definitely results in improved cosmetic results, and also lowers the risk of wound healing complications, particularly in poorly vascularized tissue. The classic example of that is pretibial lesions in older individuals. And so we typically use more protracted fractionation schemes, usually no fewer than 20 fractions with daily fractionation, and sometimes up as high as 32 fractions to doses as high as 64 gray. Why superficial electron therapy in particular? Well, electron therapy has a few physical advantages over KV X-rays as delivered by the Census machine. The first is that at the skin surface, the dose stays higher for longer. So this is what we call a depth dose curve. So the depth of tissue that we're treating is on the x-axis, and the percentage of the full prescription dose is on the y-axis. You can see with the electrons in the blue, the prescription dose is delivered almost to 100% for the first 5 millimeters of tissue, which is where the cancers typically are. We have some degree of flexibility in how deep we can treat based on the bolus we use. But in contrast with the KB X-rays at the surface, immediately the dose starts to fall off. And by the time you're 5 millimeters deep, you already have lost 20% of your prescription dose and are down to 80%. And so the thicker the lesion, the more this difference becomes problematic. Also, on the flip side of that, when you go deeper into the tissue, you'll notice that the electrons fall off much more quickly, such that by the time you're 2.5 centimeters deep, there's really no residual dose being delivered at all. Whereas the KB X-rays have quite a long tail that deliver a lot more dose, all the way through the patient and will eventually exit the other side. So on a scalp lesion, for example, the brain will receive a fairly substantive dose relative to what can be delivered with X-rays. Or excuse me, relative to what can be delivered with electrons when you're using X-rays. So the brain dose is a kind of classic example of the deep dose difference and why that's important. Dr. Casper showed this slide, but this is just one example of a patient for whom electron therapy is very useful. Just a few technical details. He had a basal cell of the right outer campus. He declined resection with Mohs, and so we treated him with 6 MeV electrons as generated by the intra-op technology. We treated to 64 gray and 32 fractions, which is our standard fractionation for cosmetically sensitive areas. That's 2 gray per fraction if you do the math. We used both a on-skin lead shield and an internal eye shield that allowed us to treat the lesion with very sharp margins, but not treat either his eyebrow above it, and also not treat his eye beneath the eye shield. You see how well that healed and how nicely and cosmetically unaltered and also functionally unaltered his eye is. So he was certainly very pleased with that outcome, as were we. To deliver electron radiation therapy traditionally required a full-size linear accelerator in a full-size radiation oncology department. These are some photos of one. This is a Varian TrueBeam, which is the standard, kind of the standard state-of-the-art device for that. These are very expensive machines. They take up a lot of space. They are in a vault that has walls 6 feet thick, typically all the way around and on the ceiling as well. And the cost of all that typically runs about $5 million or so. This machine can do a lot of really fancy things that you definitely do not need for treatment of skin cancers. And also that this machine is so bulky and expensive and requires so much shielding that unfortunately it has kept a lot of patients from getting electron beam therapy as an alternative, just because it's not as widely available as their dermatology offices. It requires more space. It's intimidating to go into a cancer center when you have a relatively favorable prognosis condition. And if the only one you have is in a hospital, you can imagine going to a hospital 32 times versus going to your dermatologist's office. It's kind of a pain. The alternative offered by Intra-Op is what they term as hospital-grade electron therapy within the dermatology clinic, which is a term I really like. And it brings a much smaller footprint machine that only generates electrons, 6 MeV electrons, into the dermatologist's office. It requires a much smaller space than a full service linear accelerator does. And as a result, requires much less shielding as well, not only because the space is smaller, but also because it generates much fewer high energy photons through radiation leakage. And as a result, the cost of the entire system is a fraction of what a full service linear accelerator would cost. And it's much easier to place in a dermatology office relative to the other one, which is really not possible. It offers a treatment time of around 20 seconds per patient in terms of what we call beam on time. It offers field sizes of up to 10 centimeters. And the beam this generates is identical to the beam generated by the $5 million machine I just showed you on the previous slide. So the actual quality of the beam is the same, and all the results and data supporting the use of electron therapy are applicable to this machine because it's the same beam. It has some really slick characteristics. The cone, which you see moving around there on the head of the machine, is actually made out of a high density plastic. It only weighs about 1.5 pounds, which it is markedly lighter than the alternative on a full service linear accelerator. In addition, with the machine, Interop provides 38 different shapes of cutout inserts that go inside the cone and that allow us to treat tumors or target volumes of really any shape we want, from rectangular to oval to circular to anything in between. As I said, the maximum field size is about 10 centimeters, but typically most of our field sizes in practice end up being between 3 and 4 centimeters. We also have the option of on-screen lead, or excuse me, on-skin lead to sharpen the beam edge even further, although the penumbra with this device is really quite good, better than what you get with a full service linear accelerator. Interop has also developed a laser reflection device within the head of the machine that allows measurement of the SSD directly from the laser onto the patient's skin. It is displayed on the front of the machine on an LCD for the therapist to easily read and set up the patients when they deliver the treatment. All this technology has allowed us to really have a very streamlined approach, and we can treat, we found between 7 and 8 patients an hour with this technology quite easily once the therapists are up and running with it. And that's a real tribute to how well this machine has been designed. You definitely could not achieve that type of throughput with a conventional linear accelerator. SET in the dermatology clinic, as Dr. Casper alluded to, it is exciting. It allows for true multidisciplinary care. It puts us as radiation oncologists in the same building as a dermatologist and gives a really neat synergy there. It allows the radiation to be delivered by radiation oncologists, which I would argue is a better and better option for the patients than having the dermatologists try to do it, just like they wouldn't want me trying to do Mohs on them. It involves a team of radiation therapists and medical physicists, which my company SET Solution oversees as part of our total package. And we together make use of our best clinical expertise and partnership to deliver patient satisfaction to these dermatology patients. We follow very rigorously NCCN, ASTRO, AAD, and AAPM guidelines in everything we do. And our billing is also very straightforward, as Jim will talk about in his next talk. In summary, radiation therapy is well proven. It's nothing new. It's an excellent option. It's supported by national guidelines. As radiation oncologists, I think most will strongly agree that electron beam therapy has some significant advantages over other forms of radiation therapy for skin cancer. The Interop technology is really unique and allows cost-effective deployment of SET within the dermatology clinic and brings this technology to a lot more people. And the SET model is really a new model that we're excited about that has demonstrated a great ability to provide non-surgical options for patients with really focus on collaboration, cooperation, and quality. And so with that, I will conclude, and I'm happy to take any questions that the audience might have.
Great. Thank you, Dr. Brabham. That was excellent. It looks like there are a few questions, and I know that in your talk just now, you covered a few of them that were posted previously, but it looks like there are a few follow-ups to those. So there had been one about lesions, and it says how many sessions are typical for one lesion?
Sure. So yeah, that's the fractionation question. Usually we find we're treating anywhere between our two most common fractionation regimens are 55 gray and 22 fractions. or 64 gray and 32 fractions. We trend towards the longer fractionation and in truly cosmetically sensitive areas such as the face, or delicate areas such as the scalp or pretibial locations. That ends up being a lot of what we're treating, because cosmesis is a big driver of patient demand for this. And all those fractionations are daily, so every day, Monday through Friday, 5 treatments, 5 fractions per week.
Okay, thank you. Another question that came in was, this machine, is it more complicated than X-ray machines, and how is the uptime?
Sure. So it is a little bit larger, and I'm not an engineer, but it is a little bit more complicated. It has more going on than a KV X-ray machine, for sure. But that being said, it's much simpler than a full-blown linear accelerator, and it's actually very well designed. Uptime has been excellent. Our uptime numbers are above 99%. I think have only had one day in which we could not treat in the 6 months we've been operating now, something to that degree. So uptime has been excellent, and intra-op and their service team are always available, and we interface with them all the time, and been very pleased with how it's run.
Thank you. The next question, what recurrence rates do you expect for the patients?
So recurrence rate, that depends on a lot of factors. The size of the tumor, whether it's a recurrence, whether it's adjuvant therapy, whether it's a de novo cancer, the grade of the tumor, et cetera, et cetera. But if I were to summarize for kind of the most common thing we treat, which is a T1 squamous cell or basal cell carcinoma, the literature supports local control rates in the range of 93 to 95% for those type lesions, and that's the majority of what we treat.
Okay, thank you. And here is another one. I believe this might be the last one. Since 1997, no large randomized studies have compared surgery and radiotherapy for NMSC. With the emergence of new technologies, isn't it time for a new study? And do you have hopes with the arrival of flash therapy?
Sure. So there's a lot in that question. First of all, as radiation oncologists and oncologists in general, we love randomized trials. So a randomized trial for this technology would be great. It would be hard to do, I think, in the United States, just because Americans have historically shown a reluctance to be randomized in trials that involve surgery. So they either want it or they don't want it, and they don't want that decision to be made by a flip of a coin. That's true across all of oncology, and so maybe our European colleague could chip in with that. But if we could achieve that, that'd be great. In terms of Flash, Flash is really exciting, and I know Intra-Op is very excited about Flash as well. The technology is largely the same in terms of physical technology of what the machine we're talking about today. It has great potential to revolutionize not only the field of SET, but of radiation oncology in general. But there's a lot of data pending on that, so stay tuned in the years ahead.